Hi everyone, Dr. Samir Rahman here from CONNOLLY Hospital, BLANCHARDSTOWN. I'm working as SHO Anesthesia with CPSP HSC training program. I'm going to present my case report titled as Anesthesia Management for whole lung lavage in a patient with pulmonary alveolar proteinosis. So what is pulmonary alveolar proteinosis? Pulmonary alveolar proteinosis is a congenital defect in which there is acid shift stain positive lipoproteinaceous material accumulation in the alveoli, which impairs the oxygen uptake and hence the respiratory failure. It is actually a congenital defect of the alveolar macrophages, which are usually involved in the uptake and degradation of the surfactant. So let's go to the case presentation. So we have this 20 years old female patient with history of shortness of breath and cough from last 3 years. She was being initially treated on the lines of COVID-19 and then asthma. And lately she was being diagnosed with pulmonary alveolar proteinosis on the base of the cytological analysis and HRCT. You can see the HRCT of this patient showing the paving pattern, which is classical of pulmonary alveolar proteinosis. Below you can see the setting we have made for this case. While presenting for the lung lavage, this patient had 92% saturation and progressive shortness of breath on minimal exertion with a restrictive pattern on pulmonary functions and normal hemograms and LFTs. Before the conduct of anesthesia, we have made a consensus with the pulmonology team whether at what saturation we will take the airway from them and ventilate both lungs. We had kept the cardiopulmonary bypass machine at backup after attaching monitors as per the ASIYA standards. Induction of anesthesia was done with sevoflurane, propofol, and cisacrocurium, while maintenance was done with total intravenous anesthesia using the propofol and dexmedetomidine, and this monitoring was used to ensure an adequate depth of anesthesia. After securing airway with the left-sided double lumen tube, right lung lavage was done as it was more involved. Repetitive cycles of installation of warm saline done and then drained to gravity. Patient had her SATs dropped continuously to 70-75% during the lavage, which improved with intermittent double lung ventilation. All of the procedure took 4.5 hours, and total of 11 liters were used to lavage both of the lungs. Patient was extubated in the OR and then kept overnight in the PACU. She was being shifted next day to the ward with a saturation of 96% at room air. So while planning for the anesthesia management in a patient with pulmonary alveolar proteinosis, a standby ECMO machine or cardiopulmonary bypass machine should be kept. If both lungs were involved, then the lavage of the left lung should be done first, as the right lung is a big one. But in our case, right lung was involved more, so it was done first. Ventilation strategies include low tidal volume, adjustment of respiratory rate to maintain end tidal near the patient's baseline or around 40 mmHg. PEEP should be kept between 5 to 10 centimeter of water. P2 should be kept less than 20 mmHg, and FI2 should be kept as minimum possible to achieve a saturation of around 90%. Maintaining normothermia, serial ABGs, optimally placed double lumen tube, and standby ECMO or CPB are the backbone of the anesthetic management in such a case. The common complications of this procedure are hypoxia, spillage of fluid, pneumothorax, hemodynamic instability, hypothermia. Vigilant continuous monitoring is needed. With proper lung separation and adequate PEEP are needed. Hypoxia has more risk during the drainage of lavage because of the shunting of the fluid through a non-ventilated lung. In conclusion, a multidisciplinary team worked with good communication, use of adequate backup plans, vigilant monitoring, meticulous lung separation with DLT, while lung ventilation with adequate PEEP, and cautious use of positional maneuvers and maintaining the vital parameters near or within the normal will ensure good postoperative outcome in such patients. Thank you.